It's actually a really good segue into my talk. So I'm Lauren Poe. I'm the medical director of the Outpatient Cancer Pain Clinic at Vanderbilt University in Medical Center in Nashville, Tennessee. And so today I'll be talking about what we've been doing in our cancer pain clinic for cancer patients and mostly patients who are in survivorship. Okay, perfect. I have no disclosures. So I think some of that is cut off, but so the first sentence is actually that the cancer population is expected to grow to 26.1 million by 2040. So those are survivors, and 40% of patients who are cancer survivors have chronic pain syndromes. And so that amounts to about 10.4 million people by 2040 that is adding to our chronic pain population. And so all of these patients are under the exemption for opioid laws and guidelines or restrictions. And my question when I first took over this clinic was, really, should they be after survivorship? What's the difference between having cancer 20 years ago and being in a motor vehicle accident 20 years ago? We don't recommend long-term opioid therapy for those patients. And kind of balancing the long-term effects of opioids that we know about now that we didn't previously, and still maintaining functionality and quality of life for patients who have gone through cancer and cancer treatment. So I think my slides are a little bit messed up, but so we started looking at our population. We see about 350 patients a year in our clinic. Or really every month through. And as you can imagine, lots of those patients are on opioids because they've had cancer, they have active cancer, or they are survivors. And so we started kind of looking and seeing, is there a way that we could start trialing tapering these patients and see how they do? And there's really no guidelines on this. There's not really a whole lot of evidence in survivorship and cancer populations specifically. Because they fall into that category. So we kind of looked at what we've been doing, started all this back in July, August, and so far about 120 patients out of our 350 are being actively tapered. We've obviously had the goals of continuing with improved function, their quality of life, and improving their sleep and their pain. We're also employing other modalities to do that as well. And seeing how far we can kind of decrease their MME or being able to taper off. We've been using objective measures to do this. So the PEG score, which is your pain and basically your general activity and your enjoyment of life. And so it's just kind of a three-question quick assessment of the pain intensity and their interference with their life. And then the FACT-G, which is an assessment of functionality and quality of life specifically for cancer patients. It looks at functional, physical, social, and emotional well-being. And then, of course, just their numerical scores. So kind of the preliminary demographics of kind of what has started out just as sort of a quality improvement project is saying like, hey, are we doing the right thing for these patients by continuing high dose opioid therapy for 15, 20 years out, 5 years out? What does that look like? When should we even look at tapering these patients? And so we've only looked at 30 charts to retrospectively kind of to see like what are we seeing here objectively. And so 17 of those patients out of 30 have no existing disease. So that means they do not have active cancer. They are not in active treatment. And about 11 of those patients had not had cancer for at least 5 years. And some of them over 10 years, up to 20. Their MMEs range anywhere in our clinic from 15 to over 2,000. And some of those higher opioid ranges are patients who are survivors. So the reason for tapering is to find a lower effective dose, a lower, safer effective dose, right? And to hopefully return them to the life they had previous to cancer treatment with no to little medication. This is done with shared decision-making. So we had introduced the idea of tapering and why we do this. So about half of those patients did not start tapering immediately. They are allowed time to think it over, come back and decide when they wanted to kind of start. And so that sort of time range is anywhere from 0 months, they want to start that month, to 8 months is what we've kind of been seeing. The overall, what we start with has also evolved. So usually there's a range of 5 to 50% decrease in the MMEs that we've been starting with. And we've sort of settled out around 5 to 10%. That seems to be the most successful for patients. They don't withdraw, or they're less likely to have withdrawal symptoms, or hyperkatifia symptoms, which is when they kind of have this sort of overall irritability, inability to sort of taper, not due to the actual opioid withdrawal symptom, but just actual, basically like the dependence of the neurobiology on these opiates. And so we're seeing, 5 to 10% really helps. And we typically do that with the longer acting medication first. It seems that patients are able to equilibrate a lot easier if you start with that. And then they can also supplement with their short acting if they need to, if they're having withdrawal symptoms, or if it was too much of a decrease in the beginning. Some of our criteria for initiating a taper, obviously we wanted adequate pain relief and functionality. So if a patient was on opioids and they are no more functional, meaning that they cannot interact in physical therapy, they can't get out of their wheelchair, they're not able to do what they want to at home, that was one of our triggers for considering trialing opioid tapering. Obviously, non-adherence to an opioid contract, although that's less of an issue for us. And then kind of deterioration over time. I was kind of seeing our patients and they have an overall sort of disposition where they're not actually more functional. Resolution of their painful condition, which is also awesome to see. If they have cancer, they get radiation, something like that, and they no longer have pain, we initiate tapers. They have a diagnosis of central pain syndrome, fibromyalgia, headaches, chemotherapy-induced peripheral neuropathy, those sorts of diagnoses that do not indicate opioid therapy. High-dose opioids, which a lot of our patients are on. So we're always looking at that and saying, hey, have we ever trialed a taper for this patient? And should we start considering that? And then, of course, if the patient requests it, which we do get. So one of the ways that we start looking at this is, first, what are the barriers to tapering? So untreated or undiagnosed depression, anxiety, which a lot of these patients also have a PTSD-like syndrome, or they can, having gone through having a cancer diagnosis or gone through cancer treatment itself. What about other things that they tried, if they've tried anything? Some of these patients have never heard of the non-opioid analgesics. They haven't gone to physical therapy or been referred to that. They haven't had an injection that might be able to help them, or neuromodulation. So we kind of start with that and make sure that they're set up kind of for success for that. And then we calculate their 24-hour dose of MME and then decrease by 5 to 10% with the long acting first. There's no evidence to support that either. It's just sort of anecdotal that is what has been successful for us. The main thing with tapering is always the discussion with the patient and making sure that you're not forced tapering, that is a shared decision making, and especially in this population, because again, they have had the trauma of going through cancer and having their life threatened. And these were medicines at that time that helped them maintain their quality of life. So it's a kind of a slippery slope, and you have to be very careful. And so the reason is why would we even do this? They're exempt, just leave them alone. And I would just argue that because now we have the evidence of what long-term opioid therapy does: central sensitization, hyperalgesia, addiction, sure. But that's not even cutting it. Mood disorders, sleep disorders, just overall decreased functionality and higher pain scores, and they just have a harder time. So why not try to balance that a little bit and see if this could improve their life. So I discussed that with the patient, this is why I'm bringing this up. It's up to you. Some patients have seen that they have stable or improved pain with lower doses. It certainly would be nicer to be on lower medication. And then kind of let them, again, ruminate on that and come to a conclusion of when they would like to start the taper. Reiterating that slow taper is the key for this. The slower you go, typically we go month by month, but we do individualize the tapers to the patients, again, for shared decision making. And not everybody's the same. They're not on the same MME. They haven't been on for the same amount of time. So if you go slow, employing your other multimodalities, then you can usually, I've found that we're being more successful at that. And then just reiterating to the patient that we're still here. We're still treating the pain and making sure that you're functional and your quality of life is still intact. And so if it's not, we'll return to the same dose that you were at. So preliminary results that we're seeing are improved function, quality of life, and overall just well-being. Their mood has really changed. I've seen patients who have been stuck in their wheelchair get out of their wheelchair and start doing physical therapy consistently, coming down, from a fentanyl patch now just on a little oxycodone and able to do that. Overall well-being, some patients will come in and say, thank you for my life back. I had no idea. I was just living in this fog. So, why does it matter? Well, I sort of touched on this, I think, as physicians and providers, we took an oath to do no harm, and everything we do has some kind of side effect, right? So we should really think about, opioids have been the main tool for cancer pain through all of this. However, what is the role? I think we need to look at it again in survivorship. A lot of these patients have central pain syndromes. And so what is the prevalence of that? And we can start looking at that with this cancer pain clinic and in survivorship, because you could easily say that, well, it was due to the chemotherapy, the radiation, the cancer, but we know opioids do it too. So are we contributing to that in their life after cancer? There's a misconception about opioid use disorder and the prevalence of that in cancer patients. There's really very little evidence to show. There was a small study that suggested maybe 20%, which is pretty high. But they're still kind of in that exempt category. And so we have to be careful and watch our own and make sure that, hey, this was a really stressful time and maybe the pain's gone, but the chemical coping may be playing a role at this time. So if we can find the lower effective dose or come all the way off, if that's appropriate for the patient, then why don't we kind of start striving to do that and give us some guidelines, maybe if that's what we're seeing is improvement. And then decrease cost to the patient. If we can get these patients down or off, decrease visits, decrease urine drug screens, decrease time. Time is of the essence for these patients, for everybody really. And so this is just a slide to sort of remind everybody why we did this and why we're continuing to do this. So I said, quoted 118 patients. We're actually up to like 150 now. We're going to start doing a prospective study, starting with the next 50 patients, where it's very standardized, because this was sort of just started as let's use our best clinical judgment with the evidence that we have and try this. And like I said, it's evolved over time. But we're seeing really good results anecdotally. So we're just going to keep going and see if we can take a look to give us a little bit more guidance in the future for this huge patient population. Thank you.